Hello everyone, my name is Shaheen Nazir Mohammed. I'm going to give you a breakdown or an overview of a poster presentation that was presented at the Institute of Biomedical Sciences Congress in 2017 in Birmingham, UK. This is a poster presentation or an outline on a hematology theme or hematological theme relating hemolytic uremic syndrome or HUS, clinical medicine versus clinical anatomy. Just to also say, in line with this poster presentation that was presented, there is a citation that you are welcome to refer to. Mohammed et al. 2017. Mohammed et al. 2017, and the paper is published. The work has been published in the journal of the Austin Journal of Anatomy, and the full title of the paper is Haemolytic Uraemic Syndrome, HUS, Clinical Medicine versus Clinical Anatomy. I'm going to give an overview, and this is research that was put together between my colleagues, myself as a scientist at the time working at the Western Area Health NHS Trust, or based in the surrounding areas of Bristol City, England, UK, and also in collaboration with my colleague Iman Abdelmagui, who was one of an academic and researcher based at the School of Medicine and Dentistry and Biomedical Science at Queen University, Belfast, England, UK, and Robert Novo, a health practitioner and a nephrologist specialist in his own right, based in Lille in France. So I'm going to give an overview with regard to this work, and hopefully this is can form as an audio that can be referred to as a guide around this particular form of renal or renal disease. So hemolytic uremic syndrome, or HUS, is an acquired disorder affecting mainly infants and young people. The triad of this clinical syndrome includes 1, thrombocytopenia, 2, thrombotic or microangiopathic Haemolytic Anaemia, and 3, acute renal failure. Terminology has been since updated from acute renal failure to acute kidney injury, or AKI, but the two terminologies can be used synonymously. That in that context, acute renal failure or AKI can develop into chronic kidney disease, or CKD. And the aim of this article was to provide more of a commentary or a review on the clinical medicine versus the clinical anatomy of HUS, because both of those areas of health are detrimented with severity, where HUS, hemolytic uremic syndrome, is concerned, or HUS, I would go as far as to say it's actually the most in a broad and blunt way, I would say it's probably one of the most disgusting forms of kidney disease that need serious attention across different aspects of health respectively. So HUS is the most common cause of acute renal failure, or AKI, in young people, or has been determined as such, with an equal agenda incidence. It is particularly more common in those under 5 years of age, and highlights a female predominance in adults. So those who are diagnosed are mainly, there's a predominance in females, and I think that might be attributed to the fact that where anatomy is concerned, there is in females there is a smaller urethra versus in females versus males, and that might be part of might be part of the might be part of the attributing, one of the attributing causes or incidences as well, or part of the incidence where this is concerned. And it is particularly more common in especially in Latin American countries such as Argentina, or at least that has been the case, or where epidemiological studies have highlighted that, and work by work by Taylor in 1999, in Taylor 2001, and in 2004, that was highlighted, and in papers by more recently in 2016 by author Akuda and his colleagues in 2016. So it is a rare syndrome post puberty, but it is also related to thrombotic thrombocytopenia, which is common in adults. To highlight again, TTP or thrombotic thrombocytopenia, TTP, is can be identified in all hematologic well-equipped hematological laboratories, and as is the case in nowadays with HUS, where HUS and thrombotic thrombocytopenia, or TTP, there is a just to say briefly, there is a similar symptomology in patients who are diagnosed with another form of chronic kidney disease, or renal disease, which I won't delve into as part of this presentation or this audio, but that is referred to as Henoch-Schloem-Purpura, or HSP, and that is picked up in is similar to HUS, and is can be picked up in older patients. When I say older, I mean older young people, i.e. those patients who are in their adults, in their adolescence, for example, versus with HUS, is picked up, patients are diagnosed much earlier in their infants and when they're young. So the HUS is attributed to E. coli or Escherichia coli, which comes from meat that is infected, and the more severe form of E. coli, that which carries a virocytotoxin producing E. coli, that form of E. coli is the infection that actually causes detriment from the start, really, and systemically from the beginning, causing problems with red cells and with blood with blood occlusion, or where there is clotting in the afferent part of the renal tubules and the glomeruli, and so there is general sclerosis when looking at this disease under biopsy or histopathological investigations in the laboratory. The VTEC infection varies geographically from year to year, and when looking at the literature or referring to the literature retrospectively, that VTEC range, it has ranged from 1 to 30 cases, 1 to 30 cases per 100,000 cases in industrialized countries, and that is what is associated really with HUS. There is differentiations of types of HUS as well, but for the purpose of this audio, I won't delve into that too much. On biopsy, there is various histopathological changes and characterized by abnormal morphology applicable to the afferent arterioles and glomeruli. The glomeruli show evidence of global sclerosis or sclerosis, and global meaning all over, generally around the glomeruli, causing narrowing and sclerosis around the functioning part of the kidneys, and as one can imagine, this is really quite devastating in young people who are diagnosed with this, and there's general glomeruli, thrombotic microangiopathy, and endothelial cell swelling. So in young patients who have this disease or have this form of renal disease, starts off as, or what might be as referred to as acute renal failure or acute kidney injury. There's cell swelling, and that cell swelling presents itself where patients are have evidence of edema or swelling around parts of them, and they would find may find it difficult to use their thinking, their ability to for example, to play and use their general skill they're developing skills where they are developing early on, those are interrupted, and in this regard, there is or along with this endothelial cell swelling, there is capillary wall thickening and glomerular basement membranes around the capillary wall of the glomeruli are also show evidence of thickening and sclerosis. There is interstitial fibroedematous change and tubular atrophy, and this is marked. It's under investigation to those who are trained to look at these things in where histopathology is concerned. It's very obvious where there are interstitial fibroedematous changes, and there is arteriolar and capillary lumina are also narrow with obstruction and intimal thickening. So the nature of the vascular involvement in the kidney supports the hypothesis that HUS is mediated by systemic toxemia, and endothelial cells are the capillary cells, and endothelial cells are the primary target cells, owing to the action of the virocytotoxin form of E. coli. So the histopathological findings are actually very important when putting linking the symptomology that the infant and young person is faced with or dealing with physiologically, and that helps the clinical teams, the nephrologists and the clinicians and the laboratory specialists to actually act fast or rapidly to make sure that the patient has the best chance of survival. Histopathological findings provide clues not only to the diagnosis, but also in the support of prognosis and the survival rate. Renal blood flow obstruction caused by diffuse arterial and arteriolar luminal stenosis may lead to irreversible changes in renal pathology. That being said, there are some treatment and care plans that can help with where blood flow would normally would either be slow or obstructed. There are certain treatments now. For example, it's not highlighted in this poster so much or in the paper that was published, but more recent work and in literature highlights that certain monoclonal antibodies, or MABs for short, actually can be made part of the treatment pathway or treatment of care pathway for patients who have HUS or might be diagnosed with HUS to to help offset some of that problem, their health, with issues where blood flow is where there's evidence of renal blood flow obstruction. And so there's general changes through the renal pathology, and diffuse tubular institutional change and sclerosis. General sclerosis indicate the degree of blood flow and obstruction, and prognosis. And in line with that, the poster presentation highlights a basis and understanding of defining features around this, further understanding around the defining features where there is renal involvement. There's evidence of coagulopathy, intravascular coagulation in the kidney, angiopathy, marked fragmentation of red cells. The disorder is associated with activation of neutrophils as well. Typical HUS is secondary to gastrointestinal infection with virocytotoxin producing E. coli, and less often Shigella. But Shigella, form of the Shigella form can confuse the HUS picture in some way. There's complement activation as well, used to attack foreign cells, in where the immune system is overridden, basically, with lots of things happening all at once. The complement system is highly regulated to prevent it from damaging healthy tissues and organs. Platelet activation, it causes damage to endothelial cells, as briefly mentioned, and white cell activation causes hemolysis, or can prompt the onset of hemolysis. So there is these are basically these can be HUS's defining features. Then there are in the poster there is some understanding around morphology and hematological features, and things. For example, the main thing really is the deformed, irregular, or helmet shell shaped red blood cells, referred to as schistocytes. And under the microscope, or where morphology is concerned, there is not only are schistocytes marked and obvious, but they when looking at the full blood count of someone who is diagnosed or has HUS, that is going to be less in comparison to someone who would be healthy, and actually in comparison to those who might have other forms of renal disease. Where there is thrombocytopenia or low platelet count, the platelet counts, where the reference range, where scientists use generic reference ranges, the platelet count for those with HUS is when someone is diagnosed with it, with that, it's obvious that the platelet count itself, or that itself, is alarming, and that would prompt the healthcare teams in the care of that young person being diagnosed to act quickly. Neutrophils may be marked as well. It is a marker of adverse prognosis. There's again part and parcel of the morphology is that patients might have would have polychromasia, a greyish tinge to some of those red cells, and there is general response with this triad syndrome. There is hemolysis. There's hemolysis, and the red cell breakdown is actually quite serious, because the red cell turnover in normal healthy individuals is rapid in one way or another. In those with HUS, the red cell turnover is also a marked part of the diagnosis. Then there's some additional points on the clinical pathology. That again, the afferent arterioles show and the glomeruli show inflammation. There's ischemic necrosis in the renal cortex, may occur from intravascular coagulation. There's glomerular thrombosis and sclerosis, hypocellularity, sclerotic. The sclerosis around the glomeruli, to the extent that the general apart from the general function of the glomeruli, the appearance of the glomeruli, which is normally can be referred to as the tuft, that is sclerosed, or it gets sclerosed, and there's narrowing in different regions. Where under histopathology or biopsy, there would be marked areas around the glomeruli where there has been where sclerosis is obvious or evident, and in line with that, there is general renal scarring. One of the other points here is hemoglobin is the most direct. Hemoglobin is one of the most important focuses that need to be maintained and controlled in infants and young people who are diagnosed with HUS. It is one of the common practices with HUS is for patients to be worked up to potentially have red cell transfusions, and the patients would be that potentially can form part of their care plan as well, routinely. And if the ultimate goal would be to have HUS patients, where HUS patients have a successful working transplant, renal replacement therapy will be part of the patient's care plan, but ultimately a transplant for such patients through their clinical pathway would be needed, or should be a part of that care plan. There is either where disease management is concerned, either hemodialysis or peritoneal dialysis treatments are essential. And when renal function is altered, it is crucial to control hypertension and thus preventing any ongoing complications. So the patient from a young age would have to be on, unfortunately, prescribed potentially more than one antihypertensive to ensure that there is adequate opening and opening of the efferent and afferent arterioles, allowing blood flow, and thus the renin-angiotensin mechanism functioning accordingly in relating to regulating long-term blood pressure. And red cell transfusion in children or young people is common, or has been common, owing to the issues that anemia or low hemoglobin causes. Fraction frozen plasma (FFP) has been administered in young adults who are diagnosed with FFP at a young age, and that has been in literature that highlights that it has been has helped, and it has offset some of the clotting or ischemia in at least where if there is a red cell production or stimulation through the hormone erythropoietin, and if a patient is prescribed erythropoietin type stimulating agents to increase red cell production, then FFP in that scenario can help with patients having who might have, for example, might have to have part of their care pathway both forms of treatment, and the erythropoietin injection that is prescribed is taken subcutaneously. That helps stimulate red cell production, and that can, if FFP is going to be used, that can actually help with some of the issues around anemia, but it can't completely offset the condition. And FFP in the long term, unfortunately, can be more harmful than actually being advantageous to patients, and so that, and thus it is why now in more recent advances, things like treatments in patients who are diagnosed may in literature highlight that certain monoclonal antibodies are more advantageous in some cases, so this is just an overview of this presentation. The poster highlights more around the laboratory investigations and some research perspectives, some more understanding, a brief additional understanding really around the clinical medicine and clinical anatomy, and I do hope that you find time to look at look around this important topic, and do feel free to go through the paper publication identified on the Austin Journal Anatomy, and that was again published in 2017 as well. And I'd like to thank listeners, and I'd like to thank collaborators for helping to put this important topic together. As the topic is very pediatric nephrology, and still more advances are happening with regard to certain aspects of treatment care plans, and hopefully this work helps provide a good basis of or overview really of what's been going on with this particular disease, this form of pediatric renal disease from a retrospective point of view. Thank you for listening. Thank you for your time.